Most lung cancer patients present with some symptoms. Obviously, a cough would be a common one, sometimes chest pain. But many lung cancer patients these days come to us with very early tumors because either they got a CAT scan for some other reason, it turned out to show something in their lung.
Healthy cells really follow the rules. They're rule followers. They grow at a very steady rate of growth until they reach their age limit. And then there is a healthy turnover of those cells such that they don't live eternally, but they do die and are replaced by new cells. In the case of a tumor cell, these cells can become immortalized and they no longer respond to the normal inhibitors that other cells like traffic signals respond to. So if a normal lung cell sees an appropriate traffic signal that says to stop, it will stop, whereas a cancer cell will not, because it no longer follows those rules, and that's what actually fuels that uncontrolled growth.
We can't pick up a cancer when it's just a cell or 20 cells or even 1,000 cells. We see a cancer when it is many tens or hundreds of thousands of cells. Only at that point can it be found on any of our tests. For lung cancer, we're typically talking about a CT scan of the chest. Usually by the time a patient has come to see a thoracic surgeon, they've had a CT scan of the chest, and they may have even had some preliminary other staging procedures to make sure that it's localized. They often have not had a biopsy, and sometimes it's very obvious to us from the appearance on a CT scan and maybe from a PET CT scan, which we have also ordered or they may have already had, that it is a lung cancer, and we might proceed directly to what I would call a surgical biopsy.
A biopsy helps us collect a small amount of the tumor tissue by removing it with a needle or a device called a bronchoscope. A bronchoscope is a long, thin, flexible tube, which is a camera, and it's slipped down into your throat to examine your airway. It helps us to get a better look at the tissues of your throat, larynx, trachea, and parts of your lungs. Sometimes we will use a procedure called a mediastinoscopy or another procedure called an endobronchial ultrasound to biopsy lymph nodes from inside the airway. Knowledge about lymph node involvement is important because if the lymph nodes in the chest contain cancer, we may recommend chemotherapy or chemoradiation prior to surgery. The job of the pathologist is to look at the cells from the lung and the lymph nodes under a microscope and to classify them as one of two main types: non-small cell lung cancer or small cell lung cancer. Small cell lung cancer is characterized by small cells that multiply quickly and form large tumors that travel throughout the body. Non-small cell lung cancer accounts for about 80% of all lung cancer and is broken down into 4 subtypes. Squamous cell carcinoma is the most common form of non-small cell lung cancer, and it is most common in men. It usually forms in the bronchial tubes. Adenocarcinoma is the most common lung cancer in non-smokers and in women. It forms in the mucus-producing glands of the lungs. Bronchoalveolar carcinoma is a rare type of adenocarcinoma that forms near the lungs' air sacs. And large cell undifferentiated carcinoma is a rapidly growing cancer which forms near the outer edges or surface of the lungs.
So once we have the tissue diagnosis, CT can be helpful in staging the disease, assessing the degree of spread. And over time, as the patient progresses through treatment, we use CT scanning and PET CTs to follow the course of disease. And so CT can give us information whether or not a lesion is getting smaller or larger or staying the same.
For stage 1 lung cancer, we can have very high cure rates with surgery alone, and that's typically what we do. Stage 2 is lymph nodes near the tumor. So for that, we're going to generally recommend surgery followed by chemotherapy. For stage 3, which is the more important lymph nodes or the mediastinal lymph nodes involved, but only on the side of the cancer, usually we're going to recommend chemotherapy before surgery, try to shrink that stuff down, and then do the operation and remove it all. Sometimes radiation after the surgery for those patients. Stage 4 patients, meaning it's spread outside of the chest, are going to get some sort of systemic therapy. Many of these tumors have specific mutations within their genes that we understand very well now, and drugs have been designed to target those specific mutations. Those are typically pills and not standard chemotherapy. If you have one of those mutations, you tend to respond much better to those pills than you do to the old-fashioned chemotherapy if you didn't have a mutation. So this is when you hear about targeted therapy. That's what we're talking about. And so that's a huge advance in the treatment of metastatic lung cancer. Depending on the size of a tumor in the lung and the location of the tumor, we might do various types of amounts of lung tissue that we remove as part of the surgery. So the lung is broken up into lobes, and the right side has 3 lobes and the left side has 2 lobes. But there are also subdivisions of lobes, and these are called segments, and different lobes have different numbers of segments. For tumors that are certainly under 3 centimeters, usually under 2 centimeters, we might recommend a segmentectomy, so where we save half or more than half of a lobe. For the smallest tumors, especially the ones that we know have very little risk of spreading, we'll do a wedge resection, which is the smallest part of the lobe that we can take out. Sometimes a tumor is in a location where we can't remove the entire tumor with just a lobectomy. From time to time, we're forced to do a pneumonectomy, which is where we have to take out the entire lung on the side of the tumor. That is less common in places like Stanford, where we have a lot of experience doing lung surgery. Sort of high-volume lung surgeons have learned ways to try to save a lobe rather than taking out the whole lung, which, as you can imagine, leaves patients with shortness of breath afterwards and a little bit limited. About 70% of patients who need a lobectomy, a removal of one lobe for lung cancer, can have that done in a way we call minimally invasively. So that can be either by VATS, which stands for Video Assisted Thoracic Surgery, or by a robotic approach. So a VATS approach is what we do most commonly here at Stanford. It involves usually 3 incisions. So a sleeve lobectomy is where in a tumor that would otherwise, or in less experienced hands, require a whole pneumonectomy, taking out the whole lung to achieve a cure, we are often able to do a sleeve lobectomy where we essentially take apart the airway and sometimes the main artery into the lung also, allowing us to get the tumor out and then reconnect, most commonly, the lower lobe artery and airway. We have quite a bit of experience doing sleeve lobectomies. So the goal of treatment in a patient with lung cancer, if it is not metastatic lung cancer spread throughout the body, is to cure them. I should say also that these days, patients with metastatic lung cancer live much longer than they used to. With targeted therapies and immunotherapies, they're certainly living far longer with good quality of life.